Good morning, everybody, and welcome to the Swim Towards Stewardship Recommendations for Action webinar. Before we begin today's session, I'd like to give you some instructions for navigating today's Zoom meeting. After clicking your Zoom link, please do join by phone as seen on your screen. Use the dial-in number and enter in your meeting ID. Please also enter your participant ID when prompted, and that will link you to your Zoom webinar so that we don't see you listed twice in the participant list.
I have for 5 years.
If you haven't already, I'll ask that you please mute your line if you're not speaking. That will help us cut down on any of the background noise from the panelist bar. Zoom is a webinar system, and it has some functions we'd like to show you how to use. In the bottom left-hand corner, you'll see a microphone icon depending on how you're linked to the audio. If you see a red line through that, it indicates that your line is muted. Currently, for today's session, we do have everybody in the view-only mode except for our panelist bar. In the middle of the screen, you will see a set of buttons. By using the chat, you can send a message to the group, and I'd encourage you to go ahead and navigate to that chat bar now, and let's practice using that. Please type in your name and your organization so we know who's in the room. If you have a question, you can click on the raise your hand icon or click on the Q&A button and type in your question. Our team will be monitoring the Q&A for questions and pausing periodically to respond. Any questions that we don't get to during our presentation today, we'll circle back to at the end of the webinar. Thank you all. I see you guys are navigating to the chat. I see many of your responses coming in, so thanks for joining us today. Just a couple final instructions as we jump into today's content and reminders. This session will be recorded, and we're going to be providing you with a link of that recording for any of your team members that missed the webinar today so that they can view the recording. This recording link will be sent out via email to the team leads and also posted within the Innovation Library. At this time, I'd just like to welcome everybody to this Fishbowl series. To those hospitals and teams joining us from the sandbar, we send a special welcome to you. We have a really unique opportunity watching the 4 hospitals participating in the Fishbowl, kind of watching as they try out different strategies and learn from their coaches during the course of this project. I'd also like to introduce our fish. So as I call on you, if you would, team leads, just unmute your line and go ahead and give a brief introduction and let us know you're here. Do we have anybody from Virginia Gay Hospital on the line? Go ahead and unmute and say hello. Jill Sandy, are you on the line?
Yes, I am.
Go ahead and give us an introduction to you and your facility.
Hi. Okay. My name is Jill Sandy. I'm the Director of Pharmacy at Kankakee County Health Center in Sigourney, Iowa. We are a 14-bed critical access hospital in rural southeastern Iowa. Going to be on RAGBRAI next week. Woohoo! We enrolled in this program to get direction in implementing an antibiotic stewardship program for our hospital. And our main reason for joining the Fishbowl is to gain insight on developing and successfully implementing that antibiotic stewardship program in our hospital.
Thank you so much, Jill, and welcome to you and your team. What about, do we have Michelle Evink on the line? Michelle, are you there? Sarah, are you on the line? Let's try Sarah Barnes again.
This is Sarah. So my name is Sarah Burns. I'm the pharmacy director at Gunderson Palmer Lutheran Hospital and Clinics in West Union, Iowa, so Northeast Iowa, for a 25-bed critical access hospital. And I signed up for this because I've been here for just over a year and we don't have anything in place yet.
Thank you so much. Welcome to you and your team. Michelle, let's try you again. Michelle, can you hear us now?
I can hear you. Can you hear us?
We can indeed. Go ahead.
Excellent. So I'm Michelle Evink. I'm the pharmacy manager at Clark County Hospital in Osceola. I'm joined by the rest of my team. We're a rural critical access hospital about 40 miles south of Des Moines, and we've implemented some great ideas about how to manage culture results and de-escalate and escalate antimicrobials as appropriate, but we'd like to do our best job for our patients, and so we're entering the project to hopefully move our efforts forward and serve our patients best. Is everybody still with us?
I'm still here.
I can hear you again.
Okay.
Don, do you want to give us an introduction to Virginia Gay? Don, are you on the line? Don Stevenson? Okay, I think Virginia.
Can you hear me now?
Oh, I can. Go ahead.
We were having trouble finding our mute button.
No problem. Go ahead.
All right, so we're Virginia Gay Hospital, located in Vinton, Iowa, Benton County, and we're joining the Antimicrobial Stewardship program. We have it up and running in our long-term care, and now we're going to focus on the hospital side. And I have our infection control people here, as well as our pharmacists and our QI people.
Very good. Thanks so much for joining us. You can all remute your lines. We'll get better at this as we progress through the Fishbowl series, and you all get a little more comfortable using the technology. So want to extend a warm welcome to all the hospitals participating in the Fishbowl and are joining us from the sandbar. At this time, I'm going to turn the presentation over to Terry Hewlett. I'd like to welcome her today. Terry is the founder and president of Infection Prevention Strategies. It's a consulting company focused on providing infection prevention consultation, education, and training to healthcare facilities seeking to either develop a robust infection prevention program or strengthen an existing program. Terry holds her bachelor's degree in nursing and is a board-certified infection prevention and control nurse. She earned the designation of Fellow in Association for Professionals in Infection Control and Epidemiology. She's been in nursing for 39 years, and her experience includes 27 years as a bedside nurse, with her area of focus being neonatal ICU. She transitioned from the bedside to infection prevention in 2006. And she spent 15 years at the University of Colorado Hospital prior to stepping outside of acute care in 2014. Over her tenure as an IP, she has been involved in multiple projects and initiatives at the local, regional, and national level, including antimicrobial stewardship and sepsis. Terry has co-authored multiple peer-reviewed articles in nursing and infection prevention journals, and has been a reviewer of APIC forms and checklists for Infection Prevention Volume 2. She's been active with the Association of Professionals in Infection Control and Epidemiology at both the local and national levels. Thanks so much, Terry, for being here. I'm going to turn it over to you.
Thanks, Kate. And thank you everyone for joining us. Hopefully you guys can hear me well. If I do get soft-spoken, don't hesitate to speak up and let me know that you need me to speak louder. It is an honor for me to be working with Kate and Iowa Healthcare Collaborative and you guys on your antibiotic stewardship initiatives. What we'll work on today and hopefully address are ways to identify key elements necessary to meet regulatory requirements for formal antibiotic stewardship programs. And that's what the regulatory agencies want to see, is that there are robust formal programs in place. We'll review the CDC core elements of antibiotic stewardship. The core elements really are the backbone of the program that needs to be developed. And then we'll describe options for action that will meet each of the core elements. What the regulatory bodies are going to look for is that at least one intervention for each core element is in place. And it sounds like a lot when we think about having 7 core elements, but so moving forward, I wanted to start out with a question and just go over why antibiotic stewardship. It's a question that I get a lot. Why do we need to do this? Dr. Kaiji Fukuda, who is the World Health Organization's Assistant Director General for Health Security, stated that effective antibiotics have been one of the pillars allowing us to live longer, live healthier, and benefit from modern medicine. Unless we take significant actions to improve efforts to prevent infections and also change how we produce, prescribe, and use antibiotics, the world will lose more and more of these global public health goods, and the implications will be devastating. So with this talk today, we'll not focus at all on infection prevention specifically or production of antibiotics. So this is another piece of Dr. Fukuda's literature, and he says, without urgent coordinated action by many stakeholders, the world is headed for a post-antibiotic era in which common infections and minor injuries, which have been treatable for decades, will once again kill. And so we'll kind of bring this all to closure at the end. Next slide. This is a map. So one of the things that we as IPs do and working in antibiotic stewardship is, what do we look like nationally? So this just shows at a national level what each state is doing in terms of having robust antibiotic stewardship programs in place. The bright dark blue states are states that really have good things going on. California is at 81% of their facilities have robust antibiotic stewardship programs in place. So the West Coast, those 3 states tend to do pretty well. California has a lot of regulatory requirements that drive some of that work. The states on the East Coast tend to do pretty well. They tend to see a lot of resistance and stuff much sooner than those of us in the middle part of the country. This is data from 2015 that was reported out in 2016. So those numbers may have changed a little bit because over the last couple of years, we really have focused more on antibiotic stewardship. But that just gives you a sense for where we're at nationally. Next slide. Okay, thank you. This is just a slide I thought, since the facilities that we're working with on this program is critical access hospitals. And so this just shows you by bed size how many facilities have antibiotic stewardship in place. And critical access hospitals, of course, in that first bar really have lots of opportunities to move forward with antibiotic stewardship. Next slide. This, I just wanted to put in as a sense of risks of antibiotic use. The 2 big ones that we worry about are C. diff. Yeast we worry about too, but this gives you a little bit of a picture of why we need to focus on antibiotic stewardship. We forget about the allergic reactions, the adverse events, and a large portion of patients on antibiotics end up presenting to EDs because of reactions that can range from a rash to anaphylactic type reactions. Drug interactions is another one that we forget about, and especially in our elderly population with lots of comorbidities who are on multiple medications, we need to really take into consideration what we're doing to them. And then antibiotic resistance, and that's a big one. Resistance is really becoming a huge issue. Next slide. This I throw in just because it's a nice it's a nice picture that kind of speaks again to why we need to do what we need to do. In patients who are in hospitals, 1 out of every 2 patients will at some point in time receive at least 1 day of antibiotics. And so there's lots of opportunity to address appropriate antibiotic use. Are we treating unnecessarily, and how can we improve outcomes for our patients without harming them? Next slide. So this is the core elements for small and critical access hospitals. And this will be one of 2 documents that I use to put the presentation together, and that you guys will have access to. More than likely, you guys have already seen the core elements. If you have not, it's available on the CDC website. What the core elements share is that 20 to 50% of all antibiotics prescribed in hospitals are either unnecessary or inappropriate. So that right there is lots of opportunity for us to make improvements in prescribing antibiotics. Patients are unnecessarily exposed to antibiotics, placed at risk for serious adverse events without clinical benefit, and that goes back to the drugs interacting with other drugs, anaphylaxis versus rashes. Misuse of antibiotics contributes to the growing problem of antibiotic resistance. We talked about that. And then CDC estimates that more than 2 million patients are infected by an organism that cannot be treated by the recommended antibiotics, and more than 20,000 of those patients will die. So that, in a nutshell, is why we need to move forward with antibiotic stewardship. For those who haven't seen this one, this is a document that came out in 2016. It's the National Quality Forum, National Quality Partners, Antibiotic Stewardship in Acute Care Playbook. This came after the core elements, and the National Quality Partners took the core elements and then drove it a bit further. So this is put together based off of the core elements, but it divides the work moving forward into a little more depth. It's a practical tool to help hospitals create strategies to adopt using the core elements. It provides a flexible structure with real-world examples for hospitals to use as they create high-quality antibiotic stewardship programs that meet the needs of their communities. And that was a statement by Dr. Arjun Srinivasan, who is kind of the father of antibiotic stewardship and was instrumental in driving some of this work. The playbook provides a comprehensive and practical plan for hospitals to implement stewardship programs that can help improve patient outcomes and reduce antibiotic resistance. And that was from Dr. Ed Septimus, who worked in collaboration with Dr. Srinivasan to really drive this antibiotic stewardship work nationally. Next slide, please. So this just spells out, for those who aren't familiar with the core elements, what the 7 core elements are that we'll go over today. And we'll talk about each of these in a little more detail. Leadership, commitment, accountability, drug expertise, action, tracking, reporting, and then education. Each one of them has a significant piece that we need to be doing. Some are easier to do than others. Next slide. So this is the checklist for core elements of hospital antibiotic stewardship programs. As we've worked with antibiotic stewardship in hospitals and in the long-term care setting, we've used the checklist as a gap analysis. The gap analysis identifies opportunities that facilities have. It helps them understand what they have in place and where their opportunities for action are. And helps them take it more at a bite-sized level. Identify where your low-hanging fruit is, especially for those who are just starting out and it might seem overwhelming, and then move forward. So the gap analysis is a great tool to start with. Next slide, please. Okay, so kind of diving right into it, I want to preface a little bit. Kate sent out a pre-survey to the participants that are participating in the fishbowl, looking for specific information about the core elements that would help us get a sense for where everybody is and moving forward where the opportunities for each of the facilities are. Based on the survey, I think I was surprised with most everybody has at least something in place for 5 of the 7 core elements. Leadership was one that was pretty good. Leadership, as identified in the Playbook and in the core elements, say that leadership is committed by hospital executives and board trustees in small and critical access hospitals as an important piece to ensuring allocation of the necessary resources to support antibiotic stewardship programs. And that's significant. Without support financially, you can't have people that are doing the work. You have to have the ability to fund dedicated time, IT resources, and all of that stuff. So next slide. So these are leadership examples from the core elements that just give you an idea of how you can implement the leadership piece. These, you don't have to implement specifically what's in the core elements or what's identified in the playbook. They're examples. So others may have other things, but an example would be a C-suite commitment in the way of a formal letter of support. Issue a formal board-approved statement on the importance of antibiotic stewardship, and that letter that your executive level issues would be something that goes maybe to medical staff office or to the unit managers and medical directors of your different units, to really help those at the unit level understand that from an executive level, this is really something of importance that the executive level has expectations behind. The C-suite person can issue a statement from facility leadership to all providers and patients highlighting facility commitment to improve antibiotic use. In the smaller communities, this has worked. In one state that I worked with, they actually did that in their community, and it created a lot of opportunity for discussion, both in the community as well as in the nursing home, in the acute care setting. It just was a nice tool to use. And then support training for hospital stewardship leaders on antibiotic stewardship. And that's a big one that we'll talk about later in the presentation. Next slide. So the quality playbook identifies leadership examples as well. And what you'll find as we're moving through is a lot of what the quality, the National Quality Playbook has mirrors what the core elements have, but then the playbook takes things a little bit further. What the playbook says is facility leadership should provide a visible written statement of support for antibiotic stewardship. And something that maybe a unit manager can put up in a common area for staff to really start thinking about and asking questions. Well, what is antibiotic stewardship? Why do we need to do it? What does it look like? Facility leadership should provide support for training and education. We saw that in the previous slide. And that can be something as much as making sure that shifts are covered so that whoever that person, that team lead is, or the other team members have the ability to commit some time to antibiotic stewardship versus expecting them to come in on a day off to do this work. Facility leadership should provide financial support and ensure that the team has dedicated time to perform antibiotic stewardship functions. And so we call that dedicated time. So if you're a 0.8 FTE, maybe making sure that 0.2 of your FTE or 0.3 of your FTE is dedicated to antibiotic stewardship, and that if your unit is busy and they're short-staffed, are you the first one that they pull to cover short areas, or are you really protected during that time? Next slide. So the other thing that the quality playbook does, which is really nice, is it breaks their recommendations down into 3 different levels, a basic level. So somebody who has no antibiotic stewardship in place and they're trying to figure out where to start, the playbook will list out for you basic elements. Here's your low-hanging fruit. Here's the things that you can start with. And then for those who have some antibiotic stewardship in place, but they want to build on what they have, you've got that intermediate level actions. And then there oftentimes are some that have that are leaders, and they've really already instituted some interventions that are working well, but they want to continue to build on it. So that's where the advanced things come in. The advanced recommendations tend to be a little tougher to implement. So for those who are just starting out, look at your basic level. Having that formal board-approved letter helps stress the importance of why the work needs to happen. And when it comes from an executive level, it tends to carry more weight than it would from the team lead maybe, or from infection prevention. So really getting that board-approved letter is a first step. The quality playbook talks about developing a newsletter with columns from the CEO or the CMO where they can talk about antibiotic stewardship, and then funding for remote consultation and telemedicine. And as we go on, one of the big barriers in my work out with critical access hospitals and the long-term care facilities is having access to an ID physician or an ID pharmacist. Oftentimes there's not a 7-day-a-week pharmacist in a lot of the facilities. So having your executive level understand the importance of consultation and telemedicine. Intermediate level might be something like having that executive serve as an antibiotic stewardship program champion. So if they're out on the units making rounds, have them talk about antibiotic stewardship and talk with the staff about it. Do the staff know what it is? Maybe staff can educate that executive leader a little bit. Include antibiotic stewardship measures on a strategic dashboard. More and more facilities are doing that. It seems like when an issue gets heightened to the level of being on a dashboard, there's more awareness of it. And it prompts questions, what are we doing? Are we seeing improvements? Is it making a difference? And then integrating antibiotic stewardship into quality improvement and patient safety initiatives. On the survey, there were facilities that said that they had quality improvement as part of their team, which is really key. One of the things that we'll talk about in a couple slides is initiative fatigue, and I'll share some issues around that. For the advanced level, you can look at ensuring you have antibiotic stewardship leaders that have training in measuring and improving antibiotic use, and then prioritize funding for information technology. This is another huge one because a big piece of the antibiotic stewardship work is tracking. And you have to be able to go into an electronic health record and pull the information out that you need to. And in many of the facilities that I've worked with, we've had to work with information technology or IT to help figure out how to capture that information. So that's a huge piece. Next slide. So the other thing that the Playbook does is it's identified barriers. The Playbook was put together with a large group of pharmacists, infection preventionists, key people in antibiotic stewardship who are already doing the work. And one of the things that the National Quality Forum asked is what would have been some of the barriers? So low support for antibiotic stewardship leaders is one that they identified. And helping people understand really the significance of antibiotic stewardship and why everybody needs to do it. So a remedy for that was to develop and share a business case. And there are different, if you go into the Playbook, it actually will help you develop a business case to speak to why antibiotic stewardship is important and why there needs to be dedicated staff to do it. Refer to national reports on the importance of antibiotic stewardship and resistance, and we'll talk about some of those here in a little bit. Direct leaders to statements on importance of antibiotic stewardship programs. We can speak, and they oftentimes won't really take to heart what we're trying to share. But if I come to somebody with a statement from the American Hospital Association or IHI or the Leapfrog Group or the CDC or Pew Charitable Trusts, they tend to pay more attention to it. So knowing how to access that information can help you drive the work that you need to do. Another barrier was low awareness of antibiotic stewardship at the board level and C-suite level. So again, just providing the information and putting it into a format that will make sense to them. one of the things that I learned pretty quickly is that antibiotic stewardship is not viewed as a money generator. Infection prevention isn't viewed as a revenue generator. But if we can explain to the executive level people the benefit that we have and how we can actually save money, we may not bring money in, but the work that we do saves lives and saves expenses that the hospital is going to see, then that tends to drive buy-in at that executive level. Encourage patients and advocates to share stories. I haven't seen a lot of that outside of Clostridium difficile. I think that's a harder one to address. And then competing priorities or initiative fatigue, and I referenced that on the previous slide with quality improvement. And I think it's a huge benefit to have quality improvement as part of your team. Oftentimes, my experience was the quality team were doing things, infection prevention was doing things, pharmacy would be doing things, and none of us realized that we were all asking the same group of people for the same information. Whereas if we work together, we can reduce that initiative fatigue because we're going to the different units as a group versus individual. And so just remembering that who else could be doing the same work that we're doing, touching base with them and trying to reduce the asks that we have at the unit level. Next slide. So this is a couple slides back, we talked about providing information reports that speak to the importance of why we're doing what we're doing. This was a report that came out by the president in 2015. It identified national targets for combating antibiotic-resistant bacteria, and it outlines goals and objectives over the course of, initially it was over a 5-year period. Antibiotic resistance threats in the United States are addressed in here, and it talks specifically about why antibiotic stewardship is important. So that's a good report to share. If your executives haven't seen it, you can pull out key pieces of information from that report that you really want them to see. So in case you haven't seen that, that's something to go look at. Next slide. So this is one other, the National Action Plan to Prevent Healthcare-Associated Infections, the Roadmap to Elimination. This gets referenced a lot. It was developed from leaders across the country. It rolled out in a phased-in approach. So, and this has been out again since 2013, I believe. Phase 1 was acute care hospitals. Phase 2, they worked in outpatient settings and specifically on influenza vaccination. Phase 3, they focused on the long-term care facilities. And now Phase 4 is specifically on antibiotic stewardship. So the document itself is a large document and can be overwhelming, but they've broken it down into phases so you can actually just go look at Phase 4 and see what they're moving forward with at the national level and what the recommendations are. Next slide, please. Okay, so on to accountability. Appoint a single leader responsible for program outcomes, and that's the big piece. We need somebody that's going to take responsibility for really looking at what you're doing and identifying what's going well. You want somebody who is going to be accountable to that executive level and be able to share the work that you guys are doing and why it's the benefit that you're seeing from it. And if not, that you're monitoring your outcomes and making adjustments as needed. Next slide. Okay, CDC Accountability Examples. And I'm not going to read all of those just because there's a lot of slides left and I want us to be able to get through them. But CDC identifies accountability examples as, it can be as simple as approving a policy. The National Quality Forum, approving a policy for the creation of your program. It's an action, it's a step. You're identifying key people that you want on it. And then integrating stewardship activities into the quality improvement in our patient safety world. And I talked about those on one of the previous slides. Specific pieces can be UTI work or sepsis management. Everybody's working on both of those. So you may as well include what quality improvement is doing, and they can be aware of what you're doing. I think I'll leave that there and we'll go on to the National Quality Partners. Next slide, please. So what the playbook says in terms of accountability examples is antibiotic stewardship programs should have a designated leader. And in the ideal world, that leader would be your pharmacist. And based on the survey that went out, everybody has a pharmacist that's leading that team, which is great. For those facilities who don't have a pharmacist, it can be a physician. And what many facilities have done is have co-leads where they have a physician and a pharmacist doing the work together. And that's another model that works really well. So I'll go on. Next slide. Okay, so basic, intermediate, and advanced levels in terms of accountability implementation. Identifying a physician or pharmacy leader is the basic one, and everybody's done that. So you all have this piece in place already. Identify a nurse practitioner experienced in antibiotic use if an MD or pharmacist are not available. And I think that's been one that people haven't thought about. If you don't have that pharmacy or physician, what is the next level in terms of somebody who's prescribing that can help drive that work? For intermediate, ensure your ASP leader has specific training in antibiotic stewardship. And this is a big one because a lot of pharmacists in our rural and remote areas are not ID trained and don't have that specific training. So we'll talk about some of those options later on, but that's a good one to really hone in on and to drive from the executive level in terms of funding to allow them to attain some type of formal education. And then for the advanced, just tying your established metrics to performance reviews. And that goes back to the accountability piece. You know, we can do the work, but if somebody's not taking responsibility to help move things forward, the work then lacks the meaning that we want it to have. Next slide. Barriers to accountability, inability to find a qualified leader. And that's been a big one, especially out in the rural settings with the critical access hospitals. And that comes back to support for training of those leaders. I think if they understand what antibiotic stewardship is and what their role is and how they can drive it forward, you're more likely to get somebody to take ownership and step up. And again, contracting with an ID physician or pharmacist, and that's where your telemedicine might come into play, and that is going to require funding from your executive leadership. Fear of disciplining rogue providers. This is a big one. Nobody wants to correct physicians, and that's why it's good if you have that physician leader who can help drive that work. Establishing a policy that defines noncompliance and corrective actions. And that was a huge one that we had to implement. If you've got providers that are outliers, if there's no one to hold them accountable, that's a big issue. Lack of coordination of different disciplines and silos of care. And this goes back to, in terms of the silos, if you've got quality doing one thing and you've got pharmacy doing something else and you've got infection prevention doing something else, nobody's aware of what's going on and you really have a disjointed processes in your facility. So making sure that you have a multidisciplinary team with identified goals and everybody's sharing and collaborating together. Next slide. This is an example of the letter that we sent out, and this will help bring together leadership and accountability. It's signed from the CEO or whoever your executive level support person is. It can be a CMO, it can be a CNO, but you need somebody at that executive level. And what it does is it spells out for them what they're agreeing to, what they're supporting, why it's important. It identifies the team that you've put together so that that executive can see who in their facility is working on it. And then it's got identified the team lead. So if that executive has questions and wants to know how things are going, they have one person that they can go to and get information and work with. Next slide. Drug expertise, appoint a single pharmacist leader responsible for working to improve antibiotic use. And both the Playbook and the Core Elements say the same thing. In most critical access hospitals, a pharmacist, usually one who is on site, provides the leadership and expertise. And we see that based on the survey results that you guys submitted back to us. All of the participating facilities have a team lead that's a pharmacist, so that's great. Next slide. Again, examples of drug expertise, your pharmacy leader. One of the things that in working in different states that we've really tried to encourage, and the CDC has really encouraged this, is include the antibiotic stewardship or antimicrobial stewardship work into job descriptions. And what happens if it's not is when somebody who has led or really been integrally involved with antibiotic stewardship, they leave the facility, oftentimes this work drops off. If it's part of the job description, whoever steps into that person's role is going to continue the work. And then making sure that there's dedicated time to develop the program, and we've talked about that earlier in the presentation. Dedicated time is huge, and it needs to be committed, dedicated, and there needs to be an understanding that the team has that time to work on it. Training on antibiotic stewardship courses, that's another huge one. And so listed here are just some opportunities where pharmacists and physicians can access antibiotic stewardship specific training. MAD-ID, Pediatric Infectious Diseases Society, the Society of Infectious Diseases Pharmacists. ID Week, usually they'll have a one-day pre-conference on antibiotic stewardship. It's great if anybody ever wanted to go to ID Week. And then the American Society of Hospital Pharmacists. So links to each of those sites are at the end of this webinar in the reference section, so you guys can have access to that if you're not aware of them already. Next slide. Drug expertise implementation, and again, there's specific ones for the basic, intermediate, and advanced. And again, the big one is providing training opportunities. You're going to meet so many other pieces to this whole program if we can ensure that we have staff leading it who are well trained. Next slide. Barriers to the drug expertise, inability to find a qualified pharmacist. A lot of pharmacists that we've talked to and worked with were a little bit leery because they didn't have formal training in antibiotic stewardship. So helping them understand where they can access that training. And then for those facilities who don't have a pharmacist that can be dedicated to this, understanding that you've got telehealth and consultant pharmacists. And consultant pharmacists have worked well. I worked with a number of facilities that have a consultant pharmacist that goes throughout a region of the state. And that's worked well for one state in particular because they have some consistency and that consultant pharmacist is trained. Insufficient funding. And that goes back to the leadership piece, making sure leadership understands that they need to fund the work that's going on, that employees aren't going to just do this for free. Next slide, please. So for action, I think for me this was a big one because based on the responses to some of the surveys, there's a lot of action going on, but the responses didn't show that. So for actions, there are a number of evidence-based interventions that can improve antibiotic use. Decisions on which ones to implement should be based on local needs. And implementing at least one recommended action which can be evaluated after implementation. I think of these two statements, that second one is one to key into because you want to pick an intervention that you can track and then report. Okay, CDC Action Examples, opportunities for a team approach, improve antibiotic use, which means accurate diagnosis. We have lots of opportunities. I have highlighted in there the UTIs. That seems to be kind of a low-hanging fruit that a lot of facilities are working on. If they can take UTIs and address appropriate diagnosing, colonization versus active infection, clinical symptoms, they can make huge improvements. 48-hour timeout. And in looking at the survey results, I think everybody was doing the timeout piece. Is the antibiotic still needed? Is it tailored based on the culture results? And how long should the antibiotic be given? Other opportunities for education. Improve antibiotic use, and there's a whole host of things there that that can be done. Next slide, please. The National Quality Partner Action Interventions. Basic intervention would be a system-wide one, looking at implementing a policy for antibiotic stewardship orders. And that goes back to, or that speaks specifically to prior approval. So you can identify what antibiotics you want to restrict, maybe. Require documentation of diagnosis, indication, drug dose, and duration. Let me just stop for a minute and see how many of you have done require indications in your physician's orders. Do they document that so that it's something that could easily be found?
If one of our fishbowl hospitals would like to unmute their line and go ahead and just share with us what your practice is for physician orders, that'd be great.
This is Sarah from West Union. We have Epic, and there is a hard stop for inpatient providers that they have to put an indication before they can prescribe the medication. For our outpatient providers, however, there's not.
That's been a big challenge. Did you get much pushback with the inpatient providers in terms of making it a hard stop?
This was something that was actually in place prior to my coming here. I was at a different facility where we were trying to, and there was some pushback, but ultimately I think they finally came around and realized the importance.
Yeah, we tried to implement the hard stop at my last facility, and the physicians overrode us, and we lost that battle for a couple of years. And then a couple of years down the road, when we saw that everybody was overriding the soft stops, they finally put in a hard stop. So that, I mean, it sounds like an easy one to implement, but that's one that we met challenges with, but it has a great impact. If they have to think about what they're ordering and why they're ordering it, it might drive a little bit.
We are part of a larger health system. So Gunderson in La Crosse, Wisconsin, we're part of them. So I think having their backing and with them already having it in place, that helped.
Absolutely. They took the hit for you guys, kind of. Okay, any more comments on any of the actions that you've done in terms of trying to implement some of this? Okay. Intermediate actions are there. The 48 to 72 hour timeout is another huge one. And I'm going to try and move forward a little bit quicker. But in terms of your team with nursing, for those who have nurses on your team, this is a great one to let them drive. IV to PO, when you, nurses know when patients are on full diets and they're able to eat everything. And if we can get them converted from IV to PO, We can get lines out. We can reduce the risk for infections in terms of that device. That's a new one that really is getting a lot of push probably over the last year or so. There's a lot of good literature that shows the benefit of including nursing as part of your antibiotic stewardship team. And that's one of the pieces that nursing really can drive. And then for your advanced example, assure timely and appropriate culture collection. And I want to touch on this just because that's an opportunity to address asymptomatic bacteriuria, when to get urine cultures and when not to get urine cultures. And then in terms of blood, educating nursing staff or your phlebotomy on proper site prep to really reduce the risk of blood culture contamination, which can drive inappropriate antibiotic use as well. Next slide, please. Action barriers. Providers and or the antibiotic stewardship team are overwhelmed by the scope of interventions, and that's really been a big one. So starting off with your low-hanging fruit, realizing what you have in place because you've done your gap analysis is going to help you overcome that overwhelmed feeling in terms of moving forward. Resistance from providers to proposed interventions, and that's going to be overcome if you have good executive leadership that will help you drive some of this work. I'm going to go to the next slide. Tracking is a big one. We do a lot in terms of putting things in place. We need to remember that we need to be tracking and evaluating the interventions and the processes that we put in place. Data are essential for informing and assessing stewardship activities. And so we need to remember that. We need to, in deciding what we're going to track, keep in the back of our minds, is it useful to the antibiotic stewardship activities that we're doing? Is it meaningful to the providers? Is it going to help them do something different or reinforce practices that they have in place? And then can it be tracked over time to assess improvements? Next slide. Days of therapy are, in terms of what you can track, days of therapy is considered the most useful measure of antibiotic use to inform stewardship efforts. And a lot of you guys are pharmacists, so I'm not going to go into any great detail on that one. And the next presentation is on, we'll include some of this. CDC uses the NHSN antimicrobial use, or the AU option. And for those who are not submitting data, antibiotic use data into NHSN, that's something that you might want to think about. It gives you some great opportunities to extract the data out and then use that for your moving forward. Tracking adherence to treatment recommendations and intervention compliance. It's important to, like I said, track what you're doing. If you institute antibiotic timeouts, track and see how those are working. Are you having some outliers? And then tracking antibiotic use at the provider level, that's a tough one. We've had a lot of pushback from that. And so you might want to start small and maybe track antibiotic use at the facility level first and then take it down to the provider level. What other facilities have done is they have identified providers by a number and not necessarily a name. And then it's prompted those providers to for the outliers. Providers start wanting to know, are we that doctor? Is that our number? Once you get them used to seeing provider level data that's de-identified, then you go to the identified provider level. And when it's been done in that process, facilities have found that it's successful. Next slide. Examples of tracking. You want to look for your basic process, you want to look at process measures. For your intermediate, you can look at your outcome measures. And then for advanced, you can look at antibiotic use measures. And I will leave that at that. Next slide, please. Tracking barriers, lack of antibiotic stewardship resources to conduct the measurements. And this goes back to that executive level. The executive who's supporting your work needs to understand what that work entails. It's not just a quick 15 minutes or 30 minutes a day. You're looking at hours over the course of time to be able to put everything together. Reviewing documentation, data collection, putting that data together so that you can disseminate it in a meaningful form. Lack of expertise for data collection, analysis, and interpretation. And this is where I think they, at the executive level, don't realize the extent of the work that goes on. Consider using audit tools or point prevalence surveys to help assess appropriate use. And then you need to decide how big or how little you're going to go, because that's going to dictate the depth of support that you guys are going to need. Lack of enough isolates to produce an antibiogram. That's a tough one. And, you know, reviewing regional antibiotic susceptibility data is okay, but in some of the states, it's been a challenge. You have to have somebody that's going to lead that and can pull that regional data together. Not all health departments function at the same level. So just that's thrown out there as an option in terms of overcoming that antibiogram barrier. And then lack of IT infrastructure and support. Ensuring that tracking and monitoring is in place and you have the ability to get your data. Reporting is huge. We've talked about that throughout the course of the presentation. Reporting data that you're collecting has to go back out. You have to get the work that's being done at the unit level, and by you guys, you need to be collating that and putting it into a meaningful form. And it needs to go out to the masses. So to the executive level, to your medical staff office, to your unit departments, so that they can see what the work they're doing is providing. Next slide, please. The CDC talks about different reporting implementation examples, and we've talked about this. Share provider-specific reports with individual clinicians. Sometimes that's beneficial, especially if you have clinicians that are not compliant. Distributing data and key elements is important for people to understand where they're coming from. Reporting implementation, again, you've got your basic, intermediate, and your advanced. For your basic, you just want to be able to start with basic, simple reports that everybody's going to understand. Include standing reports to key stakeholders. So you need to get on the calendars at standing meetings, pharmacy and therapeutics, patient safety and quality, medical staff office, and your hospital board. Next slide. Barriers, lack of trust of data and results. And this one is huge because if there's lack of trust in the data, it's going to really alienate the work that you're doing. So you need to make sure that you have people interpreting the data and preparing your reports that know what they're putting together and can speak to them. And lack of consistent reporting. I think that's the next one that's big. If you're going to start reporting data out, if you say it's coming out quarterly, make sure that every quarter you've got that data coming out, because people are going to start looking for that data and paying attention to it. Next slide, please. Education is another big piece. I think we forget about all the education that needs to take place. Providers and pharmacists can provide education, and we need to remember to take advantage of their expertise. But we also can provide education to providers and pharmacists. Nursing staff, we need to remember to include them in part of the team and to make sure that they are getting that education. And then patients and families, we need to be educating them on the benefits and downfalls of antibiotics, that they can start changing their mind frame. In terms of education implementation, every opportunity that you get, you need to be doing some type of education, whether it's via electronic, internet, intranet, employee newsletters, real time. If you're out on a unit and an opportunity presents, just take advantage of whatever opportunity there is. Included in orientation, included in credentialing, and any education materials that are available that you can share. Next slide. Here, I'm not going to go into Each one of those, again, it speaks to the basic, intermediate, and advanced, participating in whatever opportunities present. Barriers, again, number one is getting access to people to teach them. Overwhelming body of education, data is not well received, and then challenging to measure effectiveness of education to justify the resources. And so just thinking about what we're doing and how you can get that education out there. Next slide. This is just an example of a CDC tool that you can use to provide education to patients and families, all available on the CDC website free of charge. Just another tool, great tool. Another one, antibiotics aren't always the answer. We need to be providing these to our patients and families. They're all on the CDC website. So just in closing, post-antibiotic era, you guys have probably heard the term. I'm going to quote Dr. Arjun Srinivasan real quick. And one of the things that he said back in 2013 was, for a long time, there have been newspaper stories and covers of magazines that talked about the end of antibiotics, ? And he says, well, now I would say you can change that title to the end of antibiotics, period. We're here. We're in the post-antibiotic era. There are patients for whom we have no therapy, and we are literally in a position of having a patient in a bed who has an infection, something that 5 years ago, even we could have treated, but now we can't. And that's true today. We have very resistant organisms, and we need to realize that that's why we're making the changes that we're doing. Recommendations for action moving forward: identify your resources, know where your information is that you can use to drive your program forward. Build a multidisciplinary team, secure executive leadership, that's huge. Start small and build as you develop buy-in, one bite at a time. Take it little pieces at a time and then build on it. Disseminate data and reports to the masses. That's another huge piece. If you're doing all the work but nobody's seeing the benefits of the work, you're not going to get anywhere. And then education is key. Just remembering that education has to be ongoing. It's not a one-time thing. Identify your resources. This I threw in just because it's part of the playbook. It is at the end of each of the core elements, and it gives you links to all kinds of resources that you can access at the click of a finger. Next slide. I'll turn it over to Kate and let her kind of finish up.
Very good. Thanks so much, Carrie. And I realize we're just a couple minutes past the hour, so we'll wrap up quickly. We're going to encourage you to meet with your teams this month and go ahead and start digging into this content and looking at some of those basic, intermediate, and advanced actions and seeing where the low-hanging fruit is and where you could get to action with right away. I'll encourage you to email your assigned coach this week some available times that you have to meet in the coming months. If you haven't done so already, I know many of you have already met or have a time scheduled. Make sure that your team is registered for webinar 2, which is on measurement, coming up August 15th at 11 o'clock. And then contact me with the Swim Towards Stewardship project if you have any specific programmatic type questions. Again, I thank you for joining us and for your commitment to antibiotic stewardship. This information, slides, recording, and resources will all be sent out to team leads this week, as well as posted on Innovation. Thanks so much and have a great day.